Hello and welcome to the DocTrePat Podcast. I'm your host, Tanishka. At DocTrePat, our mission is to connect patients across Africa with trusted medical experts and advanced treatment options available in India. Through these conversations, we aim to bring clarity, confidence, and guidance to patients and families navigating complex medical decisions. Today's episode focuses on a group of cancers that are often detected late but can be treated effectively when diagnosed early. We are discussing gastrointestinal cancers. I'm joined by Dr. Manish Jain, Director and Unit Head of Gastrointestinal Oncosurgery at BLK-Max Super Speciality Hospital in Delhi. Dr. Jain has over 18 years of experience and is a certified robotic surgeon. His expertise includes cancers of the esophagus, stomach, pancreas, liver, gallbladder, colon, rectum, and advanced treatments such as HIPAC and PIPAC for peritoneal surface malignancies. This conversation is especially relevant for patients and families across Africa, where digestive symptoms are often ignored and access to advanced GI cancer care can be limited. So, doctor, to begin with, let us establish a clear understanding. When we talk about gastrointestinal cancers, what types of cancers are included under this category?
So gastrointestinal organ is it's a big organ. When we say it is a gastrointestinal tract, it starts from our mouth to our food pipe, which is also known as esophagus.
Mhm.
Then it comes to stomach, where actually foods getting churned, and then food passes from small intestine, large intestine, rectum, and this is known as the luminal side of the gastrointestinal tract, where food is actually traveling. But
Okay.
to support this luminal tract, we have like liver, pancreas, which are main digestive organs. Liver,
Mhm.
pancreas, gallbladder, spleen. These are additional organs which support our gastrointestinal tract. So all these organs, it's a huge organ system which includes these many organs, which helps us to digest food.
Okay. So, could you explain the difference between upper gastrointestinal
Yes.
cancers and lower
Yeah.
gastrointestinal
So upper
cancers?
gastrointestinal tract means it it is like till the stomach or first part, just first part of the duodenum, you can say, the first part of the small intestine, and then the when the food get digested and it has to get absorbed in different parts of the intestine. It
Mhm.
is all where actually absorption of food is happening. It is known as the lower intestinal tract. So primarily, if I say like upper intestinal tract constitutes of food pipe and stomach, but lower GI tract, if I have to means what we see as a cancer patients, lower GI tract mostly it is like a colonic cancers, what we
Okay.
come across, yes, which
Okay.
is also known as large intestine.
Hmm. So, why do you feel gastrointestinal cancers often receive less attention compared to other cancers?
See, gastrointestinal tracts, see, most of the time, but when we talk about any GI symptoms, it's these symptoms are very vague. And if you see the population, most of us usually have some kind of symptoms. So that's why what I feel like many times these symptoms are ignored. Many times these symptoms are treated by some local medications, some over the counter medications,
Hmm.
and the symptoms are ignored. Like if I say, like, suppose the patient is having acidity,
Hmm.
if you have eaten anything wrong last night,
Hmm.
you will have some acidity. That's common. So we cannot relate each and every gastrointestinal symptoms as cancer. So that's why the symptoms are very vague. It's happening almost to all of us every day. That's why the symptoms of cancers are usually missed, and these are less commonly focused by people.
Yeah.
But the rule of thumb is like if you have any kind of GI symptoms which are more than 2 weeks, and it is not getting corrected with your local medications, and
Hmm.
if you have to go back to your medications again after 2 weeks, then it's a time to actually visit your clinician. A simple test actually can pick up anything.
Hmm. And how do lifestyle habits, diets, and delayed medical evaluation contribute to the development of GI cancers?
Yes, so this is actually a very important aspect of how we means like if I come across 100 patients of GI cancers, and if I try to find out what is the cause of GI cancer in that patient,
Mm.
so we will be surprised to know that only 5% of cancers are only hereditary. That is like inherited cancers, which is coming running in generations.
Mm.
95% of these cancers are all lifestyle and diet related cancers. And when we talk about lifestyle and diet related cancer, it means like lifestyle means complete lack of exercise, sedentary lifestyles,
Mm.
and diet is particularly a diet which is not a balanced diet. When we talk about balanced diet, we mean to say that a diet which is very high in processed foods, high fatty meals, lot of processed meats without green vegetables. So if a person can actually balance these things together with green vegetables, with regular non-refined things, then actually these cancers are completely preventable.
Mm. Okay. So, one of the biggest challenges of GI cancer is recognizing symptoms early.
Yes, yes.
So, starting with the esophagus, what early symptoms should people take seriously?
So early symptom which we come across is like the food getting stuck in the in the chest. So sometimes patient says that when usually patient come to us in second or third stage of food pipe cancers,
Mm.
they say that when I ask them when was the first symptom appeared, usually they ignore these symptoms for at least 3 months. They
Mm.
are actually taking some water to swallow the food. So whenever you feel like food is getting stuck in your chest, it's a first symptom of food pipe cancer. And very importantly, see, food pipe cancers are one cancers where symptoms usually appear very early. And if we just pick these symptoms, that food is getting stuck, and if I have to take some water to swallow that food, it can be picked up at a very early stage, and it is completely curable.
So, what warning signs are commonly seen in stomach cancers that people tend to ignore or normalize?
So as I told you, stomach cancer is like the first alarming symptom can be just an acidity. But I don't want to like create any panic in a public that any that all acidities are cancers. No, it can be just our poor food which we have taken last night.
Mm.
But yes, again I want to emphasize is like the rule of the thumb is if you have acidity more than 2 weeks, get an endoscopy done. That's the first thing which we advise to our patients.
Mm.
And persistent acidity without any reason, having pain in upper abdomen after food intake, or pain in abdomen when a patient is hungry.
Mm.
Second thing is the third important, very important symptom which we come across is early fullness. Like if we were taking 100 grams of food which was filling my stomach initially, now I'm getting full after 50 grams. So it does not mean that I'm improving. It means that my stomach lost that capacity to expand after food intake. So it can be a very subtle signs of cancers. Early fullness after eating. So all these symptoms we should not ignore. And the last symptom which we come across is anemia. Anemia is also one symptom which one should not ignore. It
Mm.
means a person is losing blood from somewhere, some kind of an ulcer in the intestine. So all anemias in adult age or old age should be actually evaluated properly before we label them as just nutritional anemias.
Okay. So, when it comes to colorectal cancers, what changes in bowel habits and or other symptoms should raise concern?
So first and foremost is again an anemia in an middle-aged or an elderly person. We usually come across large intestinal cancers where patients are repeatedly treated for anemias for a very long time with iron, whether either with iron tablets, sometimes iron injections, sometimes blood transfusion before they come to us, and they we do a simple test which is colonoscopy or stool for occult blood, which says that yes, he's losing blood in from the intestine, and the reason is always a cancer in the right colon. So usually if I have to give you some data, then if I come across 10 patients of right colonic cancers, 8 out of these 10 patients are ignoring their anemia for a very long time. So see, if I tell you a middle aged men and a middle aged women, they are completely different people. women can have anemia because of menstrual cycles, sometimes poor nutritional intake. But a man who is actually healthy is going to office, doing his normal activity, he was feeling energetic. Now for last 2 months, 3 months, he's complaining that I'm getting fatigue more easily. A simple test like hemoglobin can tell us that he's losing blood, so he's anemic.
Mm.
Anemia does not mean that we have to just replace iron for him. It means that we have to investigate why he's anemic, and you will be surprised that the first dictum is that we have to do colonoscopy. Many times we come across these ulcers or sometimes colonic cancers in large intestine, which can be easily treatable if we pick them at that early stage.
Hmm. Okay. So, and finally, what red flags are associated with liver and gallbladder cancers that should never be overlooked?
Yes, so liver red flag is always a jaundice. If patient is jaundice, then it's always and always related to liver or sometimes bile duct. But any jaundice should not be ignored. It should be immediately brought to notice to the clinician. He will do some certain tests like simple tests like liver function test, some ultrasound that will tell us whether liver is functioning well, whether any kind of blockage is there, or that jaundice is purely because of stones. So, three basic diagnoses we have to find out. Any jaundice we should not ignore. Again,
Mm-hmm.
liver cancer symptoms. If I say the first symptom is always loss of appetite. Patient will not feel hungry. He will say that I have completely lost my appetite in last 15 days. So
It
any
can be
such
due to some medications also, maybe.
yes, see, unexplained symptoms like
Hmm.
unexplained loss of appetite, unexplained loss of weight, all these are very alarming symptoms. We should not ignore them. So it does not mean that we have to just give him medications to bring that appetite. We have to investigate them. And liver is the main organ which actually controls our appetite. If
Hmm.
anything happens to liver, some infection, some tumor, some blockage in the bile duct causing liver swelling, any problem with the liver, the first symptom is always loss of appetite, and second symptom can be a jaundice, can be a itching also. So I have picked up liver cancers, I have picked up bile duct cancers just on very simple first symptom. That patient came to me with a itching, and he was showing to dermatologist for last 1 month that itching is not going. He
Hmm.
was getting some medication, some tubes, but I told him to just get a liver function test done, and it showed that the alkaline phosphatase was on a higher side. I investigated further. It showed me a small tumor in the bile duct. It was completely curable. So
Okay.
all these symptoms we should not ignore. Just itching which is not going. No skin disease, but patient is having itching. Any jaundice, yellowishness of eyes or urine associated with itching. All these are early symptoms of bile duct cancers.
Okay. So, moving on to pancreatic cancers, it is often described as one of the most difficult cancer to diagnose early. So, why is pancreatic cancer so challenging to detect in its early age?
Yes, you are right. Pancreatic cancers, in a way, if I have to describe pancreatic cancers, these are like it's a difficult organ to deal with. Cancers are even more difficult to treat. Why? Because pancreas is an organ which is lying posteriorly, backside. It's all surrounded by important blood vessels. Blood vessels which is going to liver, which is going to our heart. Everything is going behind the pancreas. So any tumor in the pancreas. See, pancreas is an organ which controls our digestion. It's an
Hmm.
organ which secretes some
The
enzymes to
enzyme.
digest proteins, carbohydrates, fat,
Hmm.
right? So any problem with the pancreas, it means that these important nutrients will not get digested properly, and patient will have severe weight loss. So again, pancreatic cancers are difficult to diagnose. See, if a tumor is there in the body or tail of the pancreas, that is on the left side of the pancreas, they are difficult to diagnose because they don't cause any symptoms. The only symptom will be like, again, as I told you, loss of appetite, weight loss. These, if these symptoms are not picked up early, then we'll lose them. Means 8 out of 10 patients of pancreatic body and tail masses are all metastatic. Only 2 patients out of 10 we can pick up very early because they don't cause any other symptom. just weight loss, simple loss of weight. But yes, if the lesion is there in the head of the pancreas, head of the pancreas is something which is also where actually our bile duct is also draining. So sometimes these lesions, they compresses the bile duct, and patient do come to us in early stage with jaundice. So again, jaundice, as I told you, if we if we are vigilant enough to pick jaundice, do simple liver function test, do an ultrasound, we can pick these lesions at an early stage also. Again, one more thing which I would like to mention about pancreatic cancer is like uh, diabetes. In a middle-aged person who was not diabetic earlier,
Mm.
and he suddenly now getting derangement of his blood sugar, that can be a very early sign of pancreatic cancer. One thing which we have noticed. Or if a person is diabetic, but diabetic from beginning, but now he is experiencing a change in like increase in the need of more medications, he switched over to more medications, or he is needing insulin also without any significant diet change, you know so that can be a very early sign of pancreatic cancers, which we usually come across as in history when we take the history from these patients. So all these symptoms, if we pick up early, or if patient can actually go to the doctor, and if we do some test, uh, we can easily pick them. Yes.
Okay. So, are there subtle symptoms of pancreatic cancers that people usually miss?
Yeah, so see, subtle symptoms, as I mentioned, is initial few symptoms can be just pain in the central abdomen, pain in the central abdomen, or like worsening of diabetes or new onset diabetes, weight loss, a loss of appetite, or sometimes just a slight tinge of jaundice, which he may not notice himself, but yes, yellowishness of urine color associated with itching. All these are early symptoms of pancreatic cancers, which one should be aware of. Particularly if he's experiencing some persistent pain in central abdomen. See, pain radiating to back can be a symptom of advanced disease. Pancreatic cancers, they begin with pain in central part of the abdomen, but this pain, if I say, if it is radiating to back,
Hmm.
that is very ominous sign of pancreatic cancer. But then we have actually we are late, means it's already in an advanced stage when we come across these kind of symptoms.
What if a patient is not experiencing the loss of appetite, as you mentioned, but weight loss is still happening?
Yes.
Like the diet is normal, the
Yes.
patient is eating everything they want to, but still they're losing weight. Is
Right.
that the also symptom of a
Right.
cancer?
So, what you have asked me is a very relevant question. This is, in medical terminology, is what we call as unexplained weight loss. Unexplained weight loss is when we are not dieting, we have not changed our diet, we are not exercising enough. Means we
Hmm.
are in routine schedule, but still a person is losing weight. That should always be investigated, and that can be a first symptom of GI related cancers, particularly liver cancer, pancreatic cancers, gallbladder cancers. All these have like unexplained weight loss. Sometimes stomach cancers also, they have unexplained weight loss as a very early symptom of cancers.
Okay. So, from a surgical perspective, what makes pancreatic, liver, and gallbladder cancers more complex to deal with?
See, as I told you, in pancreas, it's like a organ which is more on the back side. It is surrounded by all major vessels. Any cancer in that region has a tendency to involve these vessels. Any cancer which is more than 2 centimeter in size in the pancreas, they are like most of the time they are involving major vessels. Sometimes we have to means the surgical treatment becomes very complex to deal with these cancers. And if we are dealing with these kind of cancers, big tumors, which we if we want to deal with surgical treatment, then sometimes we have to give them chemotherapy to shrink these tumors and then perform surgeries. Pancreatic surgeries are complex surgeries in a sense that when we remove some part of the pancreas, we make certain joints in the body. We
Hmm.
join the bile duct again, we join the pancreas again, we make a joint with the food pipe again, with our stomach. So these are complex operations which usually take 6 to 8 hours. But yes, if they are done in a right patient with a right indication at an early stage, they bring wonderful results. But yes, any advanced disease, it's difficult to treat. As I told you, like pancreatic cancers, they have a very means like they are naturally aggressive tumors, and an organ is also in a complex position. Yes.
Okay. And how much does the experience of a surgeon impact outcomes in these complex GI cancers?
Very true. Like a person who is performing these kind of operations on daily basis now means that's a very relevant point actually. If someone is doing totally focusing on cancers, GI cancers, those who are performing every week pancreatic cancer surgeries or liver cancer surgeries, the outcomes are it's a proven thing that dramatically improves. Leak rates are less, morbidities are less, hospital stays are less, patient can go back early home. So all these surgery related complications, what we call, drastically reduces in a center which are high volume centers, and if surgeons are purely focusing on cancer treatments.
Okay. So now let us talk about timing because timing changes everything in cancer treatment. So, how does the early diagnosis influence treatment options in gastrointestinal cancers?
See, early diagnosis means we are picking these cancers at early stage. And if we are picking these cancers at early stage, we can formulate a plan which can be minimal invasive surgeries can be performed in these kind of patients like robotic surgeries or laparoscopic surgeries, which are now proven that these are equivalent if we compare oncological outcomes for early stage cancers, and the outcome of the surgical stress which is there with open surgeries will be very less. Like patients are not kept in ICUs after surgeries, they are not subjected to like strong painkillers after surgery.
Okay.
Intestinal recovery is very fast, the hospital stay is very fast, they can go back to their countries early, they can resume to their work. And more importantly, if I say like many cancers they need chemotherapy also after surgery, colonic cancers, rectal cancers, they need chemotherapy after surgery. If suppose I perform an open surgery, traditional open surgery for rectal cancer, one thing is like I'm giving him a big scar, big wound there, which will take some time to heal, at least 4 to 6 weeks. So adjuvant chemotherapies are delayed when we are performing these surgeries by traditional ways. But if we are performing these surgeries by robotic or laparoscopy, the scars, the wounds are very small in size, they heal faster, we can actually resume their chemotherapy earlier, finish their treatment earlier, and that all small things actually changes the outcomes of these patients.
Okay. So, what differences do you see in outcomes between patients diagnosed early than those who diagnosed late?
It's very understandable and clearly visible that if we are diagnosing anything early means we are picking them at early stage. Like if I talk about colon cancer, suppose if I talk about colon cancer, if it is picked up at stage 1 or stage 2A, if I say, and if I just do surgery for them by minimal invasive way, either lab or robotics, so these patients do not require any chemotherapy.
Okay.
So you can say the recurrence rate is only 5%. 5-year recurrence rate, 5-year survival rate is 95%. Recurrent free survival rate is almost 90 to 95%. But yes, if these tumors are missed for 6 months, then they migrate. The stage is migrated from stage 2 to stage 3. It means that the adjacent tumor has spread from colonic wall to adjacent lymph nodes. It means like even though we can treat these cancers, but yes, treatment becomes complex, they need chemotherapy also after surgery. And yes, recurrence rate will be also higher, more sometimes we need chemotherapy up to 10 to 12 cycles after surgery, even though if we completely remove these tumors. So that's how outcomes are actually different from early stage cancers to late stage cancers.
Okay. So, what basic test or evaluation can help detect GI cancers easily?
Yes, so basic test is like, as I told you, if you are experiencing any kind of symptoms which is bothering you for more than 2 weeks, simple blood test like just checking your hemoglobin. hemoglobin will say that is everything is fine or not. If you
Mm-hmm.
are having hemoglobin of 11 in a middle-aged person, hemoglobin of 11, lab parameter wise it can be normal, but yes, you should know your hemoglobin. If you were 13 6 months back and if you are now 11, that is something which we should be worried about. So simple tests like hemoglobin, any anemia in a middle-aged person with no reason, any change of bowel habits, any pain abdomen, any blood in stool, any feeling of early satiety or persistent acidity for more than 2 weeks, all these are early symptoms which actually helps us to diagnose these cancers and pick these cancers at very early stage.
Okay. And what advice would you give to families who notice persistent digestive symptoms but are unsure whether to seek medical help or not?
So that's a fear which we have to actually we have to come out of this fear. We have to means early diagnosis means a complete cure of from these problems. What I can tell you, which we can assure you, and this is a fear which we have to come out. And those people, those who are experiencing any kind of digestive symptoms which are not getting control with your regular medications,
Hmm.
actually simple tests like simple endoscopy or colonoscopy, what that depends on what kind of symptoms they are experiencing. Suppose if they are
Hmm.
experiencing change in bowel habits, blood in stool, a simple colonoscopy will tell us whether any polyp is there in the intestine. See, if we regularly come across these kind of problems. Yesterday I diagnosed an 85-year-old man with a blood in stool. A simple test told me that he is having just a polyp. A removal of polyp can actually solve his problem. So it
Hmm.
may not be cancer every time. It can be just precursor of cancer. If we sometimes pick a polyp which is bleeding, we can just remove it endoscopically. That's it. It's a cure for his problem, and it will not change into cancer in his lifetime.
Yeah.
So simple things. We don't have to get worried about too much about what test will diagnose us. If it is picking things at early stage, yes, it's also curable also.
Okay. So GI cancers have evolved significantly over the years. So how has surgical treatment for GI cancers changed in the last 10 or to 15 years?
So in last 2 decades, if I tell you, we have moved on from traditional open surgeries to minimal invasive surgeries. Particularly, if I say now robotic surgeries are actually helping us. Robotic platforms, advanced robotic platforms are actually helping us to perform these all kind of complex operations. If I say about food pipe cancers, esophageal cancers,
Mm.
which actually requires traditionally, if you see, requires three kind of incisions. One is in the neck, one is in the chest, right side of the chest. Chest means like I am opening the entire chest to remove this
Okay.
food pipe and along with all the lymph nodes, and one is in the big incision in the abdomen. So traditionally, like 30 to 40% of these patients with these kind of complex operations used to have some kind of complications, and usual hospital stay was like 10 days minimum,
Mm.
and lot of pain. You can imagine if I am opening a chest, if I am giving a big incision on chest and just retracting the ribs with my instrument, big instruments, how much pain a patient will experience. But
Mm.
robotic platforms are giving us opportunity. We are performing it very routinely. Like we have mastered that technique. We have presented in many conferences, international conferences also, and we got acknowledged for that work also. And you won't believe that patient is staying like 5 to 7 days in hospital. Pain is very minimal, less complications in the sense like less chances of getting respiratory infections. We are
Mm.
encountering very less respiratory infections, and more importantly, these food pipe cancers are very near to our vital nerves, which is controlling our voice, which is controlling our breathing, so which is known as recurrent laryngeal nerves. We can safeguard these recurrent laryngeal nerves. We are not experiencing now any patients which is complaining of hoarseness of voice after these kind of surgeries. So all these technical advancements has actually evolved over a period of time in last 2 decades. Similar results can be obtained with lab, but even from better platform is even robotics. With robotics, if I tell you like like you and me are sitting across and seeing us in a natural 3D eye vision. Like we are not putting any special goggles to see each other like we see 3D cinema. A similar kind of vision can be provided by a robotic system. It gives me a feeling like as if I am sitting inside a body and performing these surgeries with my fingers very minutely and going as near as possible to that problem, and just performing very minutely, and there is no shakiness, there is no tremors. If I'm performing 8 hours surgery, there is no tremors in the instruments. And
Okay.
robotic does not mean that robot is performing surgery, it is the surgeon who is performing surgery, but there is no shakiness, there is no tremors. So that brings the preciseness, and moreover, not only technical advancements we have seen in last 15 years. Other than that, what we have seen is the precision surgery, precision oncology. Like in 15 years back, all rectal cancer patients used to get treatment, similar kind of a treatment, that you start with long course radiation, wait for 8 weeks, do surgery, give chemotherapy. That was a standard protocol. Now we have like different protocols for each and every patient. So there is no standard treatment for rectal cancer patient. We have to tailor the treatment as per the need for the patient.
Okay.
And this is how things have changed in last 15-20 years. You were asking me like how GI cancer treatment has changed. So two things I can say: technical advancements, we have now more precise instruments, and second thing is precision oncology, which has actually come up very largely in management of GI cancers.
Okay. So, what improvements have you seen in terms of surgical precision and patient safety?
So patient safety is the most important uh, aspect when we adapt any kind of technique, and there is always a learning curve. When I say that robotic surgery can be performed, but it does not mean that if I buy a robot and I can start performing that robotic surgery from the next day. There is a proper learning curve. We like in our center we have like treated hundreds of patients with robotic surgeries for advanced GI cancers, and we are even like at that stage we are training other institutes also for robotic surgeries. So patient safety comes with an experience, and
Okay.
these platforms does not mean that patient safety can be there if a surgeon has to be properly trained, first thing. But yes, if you are performing surgeries with the help of these platforms with the adequate experience, as I told you, there is no tremor in the instrument, right? If I have to perform a rectal cancer surgery, if I give you an example of rectal cancer, so rectum is one organ which is there in the deep pelvis, and it is surrounded by all important vital nerves which is controlling patient's bladder function, patient's bowel function, patient's sexual function. And I these nerves are so minute nerves that you cannot see them with your normal eyes. If you are performing open surgeries, these nerves are difficult to visualize with normal eyes. These are sympathetic parasympathetic nerves. And uh, with robotic platform, with the zoom in feature, with the magnification feature, you can actually visualize these very minute nerves. You can remove the tumor without damaging these nerves. We can actually guarantee them most of the time that yes, your sexual function or your bladder function will not be hampered after these kind of complex rectal cancer surgeries. This is actually dramatically improving the quality of life of the patients when you are performing these surgeries after adequate experience.
Okay. So, how have complications in hospital stays reduced with modern techniques?
As I told you, like hospital stays prolonged after any kind of surgery, with either if patient is experiencing any kind of complication like wound infections, or second thing is the pain. So pain is something which does not allow a patient to move from bed, does not allow a patient to get out of the hospital. And in GI system, in GI organs, when we deal with GI organs, the third thing important which adds on is the GI motility. If patient is not having adequate GI motility after surgery, if he's having bloating, if he's not eating anything, he's throwing up, we cannot discharge these patients. with all these minor minimal invasive surgeries like robotics or laparoscopy, the handling of organs inside the body becomes very less, because we are not opening the abdomen, we are not giving big cuts, so surgical complications related to wound infections, pain are very less. So most of our patients are resumed to diet on day 3, like we start them on day 1 only with liquids, but they are usually resumed to their semi-solid diet by day 3 or day 4. This is what routinely we practice, and most of these patients are out of the hospital on day 5 for routine colon and rectal cancer surgeries.
Okay, that's great. So you're a certified robotic surgeon, and many patients are curious about this approach. What does robotic and laparoscopic GI surgery, cancer surgery, actually involve?
See, robotics or laparoscopy, if I say, like, the first was an era of open surgeries, then came an era of laparoscopic surgeries where a surgeon is performing all kind of open surgeries with the help of long instruments which are entered through small holes in the body, and performing holding these instruments by standing bedside and performing these surgeries like if I simply have to explain you, like I'm eating a food with a chopstick,
Hmm.
so just performing with these long instruments, I'm moving these instruments with my hand and performing all these kind of complex surgery inside the body just to avoid a bigger cuts. And that has an advantage. With robotic system, what is there is a platform, and that platform is brought near the body. Instruments are mounted on that platform. Through
Mm-hmm.
these small holes inside the on the abdomen, we introduce these instruments, and these instruments are in a direct control of a surgeon who is sitting on a console nearby, just on the side of the patient, and he is
Okay.
controlling with his fingers the movement of each instrument inside the body. So whatever if I move 1 millimeter, that instrument will move 1 millimeter. So it is that precise, and it and there is no fatigue. If we have like if I have to perform standing 7-8 hour surgeries on a patient with the help of a laparoscope, so there is a surgeon's fatigue, which we cannot like ignore that thing.
Hmm.
Anyone as a human body will have fatigue, and what was seen in the studies is like the last part of the surgeries, particularly long surgeries, the complications, tremors, some kind of bleedings were more with laparoscopy, but not encountered. Now recent studies, what we are seeing is like if we are well trained in robotic systems, that surgeon fatigue factor is not there, the
Hmm.
tremors are not there in the instrument, because there is a platform
Yeah.
in between. If you are moving, if my head, like there is a console where I'm seeing everything,
Yeah.
that is controlled with my head. Actually, if I putting my head there, my head is touching that senses that I'm in the complete control.
Hmm.
Moment I'm fatigued, if I just relax it, it will not move. So it's so precise, and there is no lag if I'm moving. There is no lag of time also. It's not like if I'm performing something now, it is getting replicated in the patient after 1 second. No, it's exactly same time. It's all connected through wires,
Yeah.
and it's a very, I mean, it's advanced system actually.
Wow. Okay. So which gastrointestinal cancers benefit the most from minimally invasive surgery?
See, the gastrointestinal tract, as in the beginning I told you, is a vast organ. It
Hmm.
starts from food pipe to the rectum to the anal canal. What we experience and what literature supports us is like the cancers which are luminal cancers, like food pipe cancers, stomach cancers, colonic cancers,
Hmm.
rectal cancers. These are the organs which are easily doable. And we means the results are same as open surgeries, radicality is same, oncological outcomes are same. These cancers are very safe when we perform surgeries by minimal invasive way.
Okay.
And recently we are performing even pancreatic cancers also with minimal invasive way. But then pancreatic cancers, we have to very selective. It should not be a big tumor which is actually touching a vessel. It should not be a tumor where we have actually given neoadjuvant chemotherapy to
Hmm.
shrink it. So all these are very specific indications where we select pancreatic cancers also for minimal invasive surgeries.
Okay. And why is minimally invasive surgery especially beneficial for international patients who are traveling for the treatment?
It's a very relevant thing. Actually, international patients, those who are coming to us, they can visit India or any part of the world for a very limited time. And the hospital stay, the stay in our country uh, reduces when we perform the surgery by minimal invasive way, if it is possible. And they can actually go to their work very early. They can start their adjuvant therapies if it is required very early. So for international patients particularly, it is very relevant if we perform these surgeries by minimal invasive way.
Okay. So this is a very advanced and specialized area of GI oncology, which I'm going to ask you now. What is peritoneal surface malignancy, and how does it differ from the GI cancers?
So peritoneal surface malignancies, if you ask me, peritoneum is a inner lining of the our abdominal cavity. Like we are seeing a skin as an
Yeah.
outer layer, but what we
Hmm.
are seeing skin as an outer layer. Similarly, we have a inner layer also, which is below the muscles and outside the intestine, which is known as a peritoneum. Peritoneum is a very thin lining which is covering the entire abdominal cavity from all around. Sometimes we come across tumors which are like stage 4 tumors. Whenever tumor has gone to peritoneum, suppose from large intestine it has gone to peritoneum, it is known as stage 4 tumor. But these tumors have got different prognosis. These tumors are not like they behave like all stage 4 tumors. These tumors are spreading in the peritoneum, giving small deposits of peritoneum. Initially, if you ask me, like 2 decades back, 3 decades back, there
Hmm.
was no treatment for these kind of tumors. There was no surgical treatment. All these patients were like palliative treatment used to be advised for these tumors, like chemotherapy, and the 5 year survival was almost zero. There was no patient who was surviving for more than 5 years.
Okay.
But now the treatment has advanced so much. Like if we come across these kind of tumors, what we try to do is like we perform certain tests like CT scan or MRI or PET scan. We try to find out what is the spread of these tumors, what is the spread of the peritoneal in the peritoneum. We make a index. There is a known as peritoneal carcinomatosis index. There's a calculation of the spread of the tumors in the peritoneum. On that basis we can actually treat them. If it is low, if PCI index is low, we can actually treat them with chemotherapy and followed by surgeries. In
Okay.
surgeries, what we do is like we remove the entire peritoneum along with the main tumor, and we actually give them HIPAC therapy. HIPAC therapy is some kind of an advanced chemotherapy which we give during surgeries through special machines. These are heated chemotherapies which are circulated inside the bodies, and these are actually meant for killing all those remaining cells which are not visible by our eyes. These are micros to kill the microscopic cells which are left while performing these surgeries. And all these kind of advanced surgeries are performed regularly in our department, and these are very successful, particularly for certain group of patients. But yes, as I told you, and any kind of peritoneal malignancy should not be dealt in a same way. There is
Hmm.
always a proper evaluation when we plan, when we make a proper plan whether these patients can undergo surgical treatment or not. But yes, all kind of complex operations can be performed on these patients, and we have good survival rates also. Like now at least 30 to 40% of patients are surviving for more than 5 years, which was not seen initially.
Hmm.
So this is how we are dealing with peritoneal surface malignancies.
Okay. So as you explain HIPAC also in this question, this leads me to next question. What is PPAC, and is which situation it is recommended?
Yes, so PIPAC is like it's like a uh, it's also meant for dealing for peritoneal surface malignancy. It's an procedure which is performed laparoscopically. So HIPAC is something when we are completely removing the tumor and circulating the chemotherapy inside through a machine.
Hmm.
But in PIPAC, what we are doing is we are spraying the chemotherapy. We are not removing the tumor. When
Hmm.
we know that the tumor cannot be removed, but patient is having symptoms because of that peritoneal surface malignancy, particularly a symptom which is like ascites. He is forming lot of fluid inside which is troubling him.
Hmm.
What we do is like there is a special pen which is a German made pen which is known as capno pen, which is introduced inside the body through a laparoscope. That's like an instrument. Through that we spray the chemotherapy for certain time duration. There is all formulas which are there which we calculate the dosage and time duration and everything. It's a small procedure, it's a half an hour procedure, and patient is kept in hospital for 1 day only, 1 or 2 days maximum, but he needs 2 or 3 cycles of PIPAC. So the main idea performing the PIPAC surgeries is in those kind of patients where all advanced surgeries cannot be performed because of the means like the extent of the tumor is so big that we cannot remove the entire tumor, and the symptoms are troubling him.
Hmm.
Particularly is forming like fluid in the body which is causing distension of abdomen. So these are like palliative treatments which are there, which are we are also, our center is also certified for PIPAC surgeries, and we are
Okay.
performing it for selected patients for peritoneal surface malignancies.
And which patients are typically considered suitable candidates for these advanced treatments?
So patients, as I told you, like peritoneal surface malignancies where the spread is there in the peritoneum, even though they are stage 4, but yes, the spread is limited. It's not like widespread spread. It's like we calculate the spread by CT scan and with diagnostic laparoscopy also.
Hmm.
We make a PCI index. These are all suitable patients, and more importantly, if I say more than spread, is the general condition of the patient. If patient is having good general condition, is in middle age, is not very old age, we see a good prognosis in them. Biology of the tumor is also very important. We take the biopsies from these tumors, we send them for advanced molecular test.
Hmm.
With molecular test we find that there should not be any mutation in these tumors which are very dangerous mutations.
Hmm.
So all these things are combined together, we make a proper plan for that patient. Yes, the biology is also good, you are in a correct age group, and your tumor is not also like to that extent that we cannot remove it. So these
Hmm.
are the ideal patients where we should perform all these advanced procedures like HIPAC or PIPAC. So and believe me, like they can actually survive and they can be cured also sometimes
Wow.
with these surgeries.
Okay. So we are seeing a growing number of patients from Africa coming to India for GI cancers. So why do you think more African patients are choosing India today?
So in India we have like if I talk about our centers, we are like advancement of technique is at the like now if you ask me like international standards, Japanese standards,
Hmm.
US standards, UK standards. In India, technical advancement is at that level. Actually, we are performing surgeries, we are publishing our work, and we are presenting our work in international conferences, and we are getting good acknowledgement also from these conferences. So
Hmm.
technical advancement is there. We have lot of all advanced facilities along with surgical, which a surgical patient needs, like a
Hmm.
proper ICU care, cardiology backup, intervention radiology backup,
Yeah.
neurology backup. Everything is there round the clock in all big hospitals. Then the cost effectiveness, the cost of the treatment of these advanced surgeries are very very high if you go to any other country,
Huh.
but cost
Exactly.
effectiveness is there in India, particularly if I talk about our centers.
Hmm. Okay. So how does the quality of GI cancer care in India compare with the other parts of the world?
See, if I say comparison from other part of the world, if you ask me particularly where have you got your training from, part it from India, but part it from like many other internationally renowned centers, particularly like National Cancer Center, Tokyo, Japan, or Asan Center, Korea. So all these centers we usually go, we got trained ourselves. If you ask me about the quality of surgeries, it's similar what we are giving to our patients as compared to the international centers, because there are set guidelines. For
Hmm.
stomach cancer, if I have to perform surgery, that is a standard guidelines, what kind of lymph nodes we have to remove, what kind of surgeries you have to perform to call it a radical surgery. In
True.
colon cancer we have like station wise lymphadenectomy. So there are standard guidelines which is followed in our center, and these guidelines are followed everywhere from Japan to UK, from US, everywhere. So that's why I can assure you that quality of surgery is all absolutely same what we you can call it as an international standards.
Okay. So, how does affordability play a role in these decisions without compromising the treatment standards?
So that's a main issue, when a person is getting treatment for cancer in a middle age or young age, and affordability is a main issue because so treatment is for cancer become is getting costly day by day.
Hmm. True.
Sometimes not only surgery, surgery, beyond surgery there are many things. Patient has to stop their work for a long time.
Yes.
The support for the family is like maybe he's the only earning member
Person.
of the family. The support of the family is not that much there sometimes. And other than surgeries, sometimes patient has to go chemotherapy, sometimes immunotherapy. See, combined together, if I say the treatment becomes very costly,
Hmm.
he is going through that emotional stage, emotional uh, uh, aspect of the cancer treatment. He's sometimes in particularly young patients when we come across cancers, they are in the stage where they are in the deciding factor of their career, their job
Hmm.
securities, and so many things. So affordability is an issue. That's why if treatment cost is less, and if we are performing these kind of advanced treatment with international standard guidelines, and and we if we are using minimal invasive surgeries for these kind of patients where they can actually resume their work quickly,
Hmm.
they can go back to their offices, join their work quickly, so definitely they are that going to have help them.
Yeah. Okay. So, and what reassurance would you give to African patients who are considering traveling abroad for treatment for the first time?
So I can assure you that any kind of treatment which is available in any part of the world is available in our country and at our center. The treatment is not formulated by only one doctor. There is a team of doctors. Every cancer patient case is properly analyzed by a surgeon. Then these cancer patients records are all presented in a tumor board where a proper plan is made which is shared with the patient, and we start the treatment when your understanding is there about the complete treatment plan. It's
Hmm.
not about like cutting short your treatment by giving less treatment or wrong treatment. It's all about making a proper plan for the patient as per your stage, as per your convenience sometimes, and it should be as per the guidelines. So I can assure you that a proper planned treatment will be there for all the patients who are visiting us for cancer treatment.
What makes BLK Max a strong center for GI cancer treatments?
See, when I say that our center, PLK Max particularly, is a very strong center for GI cancers management, is because, see, you won't come across a separate GI cancer department anywhere else in many institutes.
Hmm.
So GI cancers, GI management, or what we call is like any kind of GI surgeon who is dealing with cancers, they do treat all kind of GI related problems from hernia to cholecystectomies to GI cancers, sometimes obesities also. So but as I told you in the beginning, is like the outcomes are driven by the expertise what you have in that particular field. If suppose I'm dealing with only cancers, so day and out I'm only seeing cancers, and what Max has recognized is that they have developed this specialty GI oncology as a separate wing. They have developed it as a separate department
Hmm.
where we surgeons are only focused. We have a team of surgeons, medical oncologists, radiation oncologists. They're only focusing on management of GI cancers. That's why the outcomes are all driven by the experience what we are having. So there is no mixing of any kind of patients. Like other GI related patients are all managed by different teams. Only
Hmm.
GI oncology patients are what we are dealing with on a regular basis.
Okay. And how does having a multidisciplinary cancer team improves patients' outcomes?
See, MDT meetings are a crucial, you can say, a backbone of any kind of cancer management. If I say, as I told you, like any cancer patient, if I am seeing, even though if I know the treatment that it is a stage one tumor, I have to just do perform surgery. That's okay. Means like, but every cancer patient has to a file should go through MDT meetings. MDT meetings means like a meeting which is happening twice in a week, or you can we can actually make it as per the need of the patient. If it is an international patient, we can actually call it SOS, and we can have it on daily basis also.
Hmm.
And it is attended by medical oncologist, radiation oncologist, pathologist, even a radiologist,
Hmm.
and even palliative care physicians also attends our MDT meetings. So all group of doctors sit together. We introduce our case, we introduce the imaging what we do perform in all patients. Even though treatment is very simple, but yes, that gets consensus opinion of MDT meetings. But for complex management, like a patient who needs chemotherapy before any kind of surgeries,
Hmm.
these MDT meetings becomes a very crucial part of the management actually to take proper decisions.
Okay. And what role does advanced infrastructure and robotic technology play at BLK Max?
See, we have like all kind of advanced platforms we can, as per the international standards. For robotic platforms, we have like intuitive platforms, XI
Hmm.
system specifically dedicated for GI oncology, and separate OTs, separate instruments, separate post-operative ICU cares. So all kind of advanced infrastructure is available at BLK Max for the management of these complex cancers, which are actually helping us to give us a very good outcomes.
Okay. And how does the hospital support international patient beyond surgery and treatment?
So hospital is BLK Max is known for means managing international patients. Not they have not started recently. It's a number one hospital in Delhi for management of international patients. Right from the facilities which they provide the patients from. When they are not even admitted in hospitals to their whatever needs regarding the facilities which they need for admissions, their food, and their travel, and uh, and very cost sensitivity is there. Whatever issues regarding any language problem is there, we have all 24 into 7 translators are available in our hospitals to help them out in any kind of situation, whatever is needed for international patients.
Okay. Many patients worry about the process of seeking treatment in another countries. So, how can a patient from Africa begin the consultation process early?
So that's a very relevant point. Yes, whenever we are traveling for any kind of treatment to any other country, we have issues like the safety issues. We have like emotional issues. So the consultation starts from their country only. You send us a report, we reply them. Many times we try to make WhatsApp groups for the patients with the families, so that they can, it's not like a one time process where you can gain confidence in the team who is treating the patient. We try to build up a connection with the patient and their family, so that we have our numbers with them. So pre-operatively also we try to share through these kind of information through WhatsApp groups,
Hmm.
where our facilitators with doctors, with the patient and their family members are there together on one platform. They can share their concerns, their which are to be addressed by doctors. Sometimes small issues, small concerns which are bothering them, which can be
Hmm.
solved through these measures. And we make a proper plan, as I told you. And post operatively also, like once they are once they have gone to their country back. See, GI cancers is not about like they come across some kind of minor issues. Like sometimes they call me like, doctor, I'm suffering from constipation for last 2 3 days. What should I take? If I'm not approachable, it becomes difficult for them to
Hmm.
have that advice in their country or some other doctor. So what we try to do is always like we continue that consult approach. In post-operative periods, we personally give our numbers to them, or we make a WhatsApp group. They can always share their concerns, and we try to help them through these measures.
Okay. So once medical reports are submitted, what happens next?
So they are like whatever what our advice is, like medical reports should be submitted in a proper format, in a proper in a whatever all medical records you have should be submitted. It should not be like in a one single page report should not be submitted. It should be given whatever has been done so that we can analyze them properly. We can make a proper plan for these patients, whether these patients need direct surgery or sometimes they need to visit us for more investigation, so that we can make a proper plan for them. Sometimes they need chemotherapy first followed by surgery. So suppose if like I can give you an example of our recently treated patient from Ethiopia. She visited us with a tumor in the rectum. Rectum is an organ which is there. It is a large is a last part of the large intestine which is there in the deep pelvis. So she was having difficulties, bowel habit difficulties with blood in stool, and she was diagnosed with C rectum in her country. She visited us. We analyzed the reports. We found that there are two tumors actually. One was there in the rectum, and second tumor was there in the more proximal part of the large colon, which was in the sigmoid colon. So a treatment was planned. See, rectal tumors are those kind of tumors where we cannot directly perform surgeries. So we convinced that patient that yes, you need some kind of a neoadjuvant treatment, means like a treatment before performing surgery, like a chemotherapy or radiation therapy, to shrink these tumors to get a very good outcome after surgery. So we gave her chemotherapy first. We started the treatment. She responded well. Then we, in a multidisciplinary team meetings, MDT meetings, we decided that this rectal tumor is still needs radiation also. So we decided to go ahead with radiation. And once she completed the complete treatment, means when we were trying to perform the surgery, we again did a colonoscopy. We actually marked the proximal lesion with our endoscopic tattooing technique. This is an advanced technique where we actually put a dye from inside to exactly mark that proximal tumor. And when we performed that surgery, the surgery was performed robotic. By robotic means the entire segment of the tumor with intestine which was harboring that two tumors were removed. And to our surprise, after surgery, not only those two tumors which shrinked very well after chemoradiation therapy, she was found to have two additional lesions. It means like she was harboring four lesions, not only two lesions, which was actually not picked up because of colonoscopy. Because of the tumor, we could not proceed our colonoscope more further. We checked everything on intraoperative colonoscopy. There was no other tumor left inside. All four tumors were removed comfortably, and she has gone back like in 2 weeks time only. She was able to travel back to her country. She was kept in hospital for 5-6 days only. She recovered like as if means it's like a normal procedure for her, without any big abdominal wounds or any incision, as because the surgery was performed by, again as I told you, by minimal invasive robotic way. So this is how we can actually, MDT meetings, repeated discussions with family can actually change the management plan for these patients.
Wow. Okay. So when patients arrive in India, how are diagnosis and treatment plans finalized?
So treatment and diagnosis plans are first made by a surgeon who is seeing the patient. Then we do all kind of necessary tests which are required. Sometimes they have already done some kind of imaging in their country, like suppose they are carrying with them some CT scan films or CD. We submit these CDs in our radiology department, analyze them in detail. If these films or CDs are not available, then we actually repeat it. Sometimes, like suppose I have to deal with rectal cancer, I need a PET scan and MRI as an investigation of choice to make a proper plan. All these reports are subjected to MDT meetings, and we make a proper plan and then perform treatment and start the treatment immediately. In 1 or 2 days, we can actually start the treatment.
Okay. And how is follow up care managed once patients return to their home country?
So follow-up is same for all kind of cancer treatments. Is like GI cancers. What routine follow-up is required is like every 3 months they have to undergo certain kind of test,
Hmm.
which can be like a some along with clinical examination. Ideally, it has to be combined with clinical examination by a doctor who has treated. But many times we see a problem that international patients cannot visit us very frequently. Every 3 monthly they cannot visit us for proper clinical examination. But
Exactly.
in that case we advise them to go test in their country. We do sometimes do again like video callings or something like that, and encourage them to even take the help of local physicians, local surgeons also, those
Hmm.
who actually diagnose them with their initial cancers, to perform clinical examination.
Yeah.
And certain tests can be done in their country, and we encourage them to visit at least 6 monthly to for initial 2 years to have a proper follow-up. See, usual follow-up is like 3 monthly for 2 years, 6 monthly for 5 years, and then yearly at least for lifelong. That's a usual follow-up which is required for any GI cancer patients which is properly treated with surgery or chemotherapy.
Okay. So, patient stories often bring hope to others. So, could you share a gastrointestinal cancer case where the recovery was especially meaningful?
So there are many stories, there are endless stories where we deal with kind of a complex operations. We perform these surgeries where actually when we start with there is less hope. We formulate a plan where surgeries are performed and they go back very earlier to their work, or means cancer is almost curable. Recently, like if I have to share you one uh, example of a lady who was brought to our department with a with a diagnosis of right colonic cancer. Right colonic cancer is a cancer, if you ask me, it's not a very difficult cancer to treat. But when we investigated her more details, we found that she was having another cancer in left ureter. Ureter is a pipe which connects kidney to urinary bladder, so it's a
Hmm.
passage from kidney to urinary bladder. She was harboring two cancers, one in the right colon and one in the left ureter.
Hmm.
That made her treatment very complex, and to add to the complexity, she was having a big clot in the vessel which was going to the heart. So she was having a IVC clot. So
Hmm.
that IVC clot was, to our surprise, was not related to cancer. It was not a cancerous clot. So it means the both tumors were curable, but she was having technical difficulties where the clot was very near to the blood vessels, in the main blood vessel, and very near to the heart. So anytime these clots, the problem with these clots is like anytime these clots can break and can migrate to chest and can block the main vessel of the chest. So that was a challenge which was there in front of us. So in the beginning when we see these kind of patients, like means it's very difficult to give them immediate answers, with multiple discussions, MDT
Hmm.
meetings, again discussions with other teams, cardiology, vascular surgeons, urologist. We made a proper plan for this patient. What we perform is like we place a IVC filter for these patients. We place an umbrella kind of a thing through endovascular procedure above the clot so that these clots should not migrate to the chest. And
Hmm.
we gave her a thrombolysis therapy. She
Hmm.
was kept in ICU. A thrombolysis therapy was given where clot was actually melt with the help of the medicines. And once that clot got stabilized, after 15 days, we performed surgeries for both these tumors. We performed the surgeries for both these tumors, and to our surprise, both these tumors were very early stage. Both were like stage 1, stage 2 tumor,
Hmm.
and she did not receive any chemotherapy. She is absolutely fine for last 6 months. She is coming to us in regular follow-up. Clot has resolved. There is no clot in right now. Tumors we have already taken care by surgery. There was no chemotherapy which was given, and we can say that she's in a state, we can actually label her like cancer free in after a proper follow up of 2 years. I can we these are the difficult scenarios we usually come across where Initially when you see like situation is very hopeless, but with proper discussions with multiple teams and in your team members, you can actually find a very good solutions for these kind of complex patients also.
Okay. So, what has been your experience treating international or African patients?
So we have treated a lot of patients from African countries. So mostly colonic cancers, they come very frequently visit us from African countries. And like I mentioned, we have treated recently one very complicated case from Ethiopia. And so GI cancers are actually very prevalent in African countries, and they need a very complex treatment sometimes. So we can assure you that from African countries, if patient is coming to us, we can actually provide them with the international standards treatment with a good outcomes.
Okay. And how does successful treatment change a patient's quality of life and outlook?
So a successful treatment means like see, treatment, cancer treatment means like you are curing the cancer, you are making the patient cancer free. At the same time, we are giving them a very good quality of life. So that becomes relevant in this present era where we are actually, when I say good quality of life is like I'm not giving him some kind of a permanent damage with my treatment. So this is particularly relevant for those kind of cancer treatment, like suppose if I say rectal cancer treatment, if I'm preserving his nerves which is controlling the bladder or sexual function, I'm not giving the patient any permanent damage because of the treatment. So these are the factors which are very very important for good quality of life of the patient, that they are not having any kind of urinary problems or sexual problems after treatment. Similarly, food pipe cancers, if I'm preserving those nerves which are controlling the voice of the patient. So I have treated like food pipe cancers in a patient who were professionally singers, for them voice is their main livelihood.
Yeah.
So you can say that if I can preserve their voice, at the same time I'm giving them radicality and I'm curing these patients from cancer. It's the most important thing. Quality of life is the most important thing right now when we treat these complex patients.
Okay, great. So now I'm going to just ask you quick questions. This is a rapid fire round. So, to start with, one gastrointestinal symptom people should never ignore.
Blood and stool.
Blood in?
Blood and stool.
Okay. One common myth about GI cancer you would like to connect.
So GI cancers are always advanced cancer and they are not curable. This is a myth. These are most of the time curable.
Okay. One habit that supports better digestive health.
Regular exercise and a balanced meal. Balanced means add veggies to your diet regularly. If you are non-vegetarian eater, strict to don't take smoked meats to a large extent. Avoid smoked meats, red meats, and add veggies to your diet regularly with a regular exercise plan. This is this is a formula for preventing GI cancers.
Okay. And one habit that supports better digestive health.
Better digestive health is a balanced diet, which is the most important thing. And timely, what we are eating is not what we are eating, but is also what when we are eating those. So eating right thing at a right time is the most important thing, which can keep our digestive health in a good shape.
Okay. One surgical advancement that changed the way you practice.
I can say robotic surgeries.
Okay. One message you would like to share with patients across Africa.
Across Africa, I can share that just don't get a fear of any kind of a cancer. Early action means a complete cure from GI cancers.
So, before we close, Doctor, what message would you like to give to patients across Africa who may be delaying treatment because of fear of uncertainty?
So the message is very simple, that the fear you have to overcome. Any kind of symptom which is bothering you for more than 2 weeks, just bring that to the notice of your local clinician or a local surgeon. A simple test can actually pick up these kind of cancers at a very early stage, and I can assure you that these kind of cancers are completely curable if they are picked up at an early stage, and don't get fear of that.
Okay. If someone wants to seek an expert opinion or share medical reports, how can they begin that process?
They can always share to us through our medical platforms in a process way where they can share their reports. We can always provide them with our opinion as early as possible, and
Okay.
then they can approach us very easily through the medical websites, through our hospital websites.
Okay, moving to the last question. What advice would you give to families facing a GI cancer diagnosis today?
So any kind of cancer treatment is a treatment. It's like a treatment not done by the patients, not done on the patients. It's not done by the doctors. It's a treatment which is there, which has to be done by the entire family with the help of our doctors. So emotionally, we have to be very strong when we are dealing with any GI cancer patient in our family. We have to support him. So for family, the message is very clear, like these tumors are very much curable. So just support them for 6 months, 8 months. They will be back in their lifestyle, back with you, with the as like they were there previously before suffering from any kind of cancer.
Thank you, Dr. Manish Jain, for this insightful conversation today.
Thank you.
To our listeners, early actions and the right medical guidance can make a life changing difference. If you or your loved one is dealing with gastrointestinal cancers, you can reach out to DocTrePat to explore expert consultations and treatment options in India. Thank you for joining us. This is Tanishka, and I will see you in the next episode of the DocTrePat podcast.